Neuroimaging is complex. We feel that MRI and various tests would give us straightforward answers, but that is not true. As we have seen from excellent talks, the previous 3 talks, it's not so simple. It's not A, B, C, D, or 2 plus 2 is equal to 4. Similarly, brain tumors, really complex. So let's see how we can benefit from these 15 minutes and learn something about brain tumors. What is important to know about the disease burden? It is 1 to 2% of cancers. 1 in 10,000 people will end up with a brain tumor. As far as age is concerned, the majority of brain tumors, they occur in the elderly. To understand brain tumors, it is very important to know what are the types of cells in the brain. These are the neurons, primarily for which the brain exists, that is the nerve cells. The glial cells, these are the support cells, which fill in the spaces between the neurons, which generate signals and transmit signals. So glial cells are the support cells. These are the oligodendrocytes which produce the myelin around the axon so that there's no short circuiting between the electrical activity of adjoining neurons. There are astrocytes who provide physical support, and there are microglia which provide the immune. These are the immune cells of the brain. So any of these could get malignant. Similarly, there are ependymal cells which line the ventricles, and the endothelial cells which line the blood vessels. All these can give rise to tumors. It's a huge array of differential diagnoses for which WHO has been forming big bodies, and they have been coming up with classification of brain tumors so that we can have some organization in these variety of tumors that are there. So they subdivide the tumors based on pathology, natural history, patient demographics. What's the advantage? We can prognosticate, and specific tumors can have specific treatments. Till date, there have been 5 versions of WHO classifications, started in 1979, primarily based on histology. As the histology improved, immunohistochemistry came, and now that the molecular genetics has come up, we are with CNS5, as they call it, the 5th edition, which came in 2021. And the major change that has come up is that histology is important, but more important is the genetics. So if the molecular genetics says that this is what it is, that is what it is. So the diagnosis is based on molecular genetics. The grade is based on histology, even when the diagnosis is by molecular genetics. So histology is still the foundation. So there is a wide variety of tumors, and if I may write it in simple black and white slide, they could be glial, neuronal, glioneural, ependymal, choroid plexus, pineal, embryonal, cranial and spinal nerves, meningiomas, the mesenchyma, which is non-meningothelial, melanocytic, hematolymphoid, germ cell, pituitary, the cellular and the other cellular and the paracellular region, and not to forget the metastasis. Huge arrays. And each one of them have different names further. So really a complex thing, not very easy. People could spend their lifetime learning about brain tumors and still say that we are learning more. But there are certain things which are inescapable for us to know. With the CNS5, we should know that the gliomas, which are the commonest tumors in the primary tumors in the brain, these have been divided into diffuse and circumscribed. Most of them diffuse. Diffuse can be adult type and pediatric type. Adult type can be oligodendroglioma, astrocytoma, or a glioblastoma. Pediatric type are divided into low grade, high grade, and another variety known as infant type hemispheric high grade. These further have certain names in them. As far as circumscribed are concerned, these are pilocytic astrocytoma. High grade astrocytoma with piloid features is a new addition in this CNS 5th edition, and an astroblastoma, this again is new. So let's see, how does molecular genetics come into it? I have taken down just the key points out of various things so that we can at least take home certain things. We keep hearing about IDH mutation and a wild type. Wild type means there is no mutation. One would feel that wild would have mutation. No. Wild type means there is no mutation. If there is an IDH mutation on molecular biology, it's an astrocytoma or an oligodendroglioma. Whereas a glioblastoma, which is the most notorious as far as shortening the lifespan is concerned, does not have an IDH mutation. Then there is something known as 1p19q deletion. If we have an IDH mutation positive, it could be an astrocytoma or an oligodendroglioma. If it has 1p19q deletion, it is oligodendroglioma. No two ways about it. I want you to focus on the heading called others. Why is molecular biology important? It has been realized that genetics plays a major part. In our cells, in our body, mitosis keeps on taking place. We have certain genes which are promoter genes, certain genes which are suppressor genes, certain genes which are suppressor of promoters, certain genes which are promoters of suppressors. If you can just understand this concept, it will come to our mind that if we have genetic configuration where we have tumor promoter gene in our body, we will end up with cancer. If we have a suppressor gene for mitosis, we are unlikely to get cancer. If we have a promoter of suppressor, all the more less chances. If we have a suppressor of promoter, then again we have less chances of getting a cancer. This is why molecular biology is gaining its importance, because it is like your palmistry or the horoscope that is written, that well, this is bound to happen. So genetics and molecular biology is something like this. We, as radiologists, need not know about this. But what is important to know is that we are not the final word. The final word will come from biopsy. And in biopsy, it is histology and molecular. So if I have to summarize, as long as we can say that this seems to be a neoplastic lesion, not an infective lesion, it seems to be a high-grade neoplastic lesion, I think we have done a great job. And that is what we should focus on, that is it a tumor or not a tumor? Is it high-grade or low-grade? That is at the time of diagnosis. And thereafter, to know how is it progressing. Is it responding to the treatment? Or it is not responding to the treatment? And there are times when there is a pseudo-progression or radionecrosis which can confuse with a live tumor. That is what is our main role as imaging specialists. So let's take this journey, not an easy one, but let's see how we go about it. As far as pediatric type is concerned, all that we should know is something known as histone 3 mutation. So if a histone 3 mutation is present, it's a diffuse midline glioma, that means like a brainstem glioma, they will have this. It could also be diffuse hemispheric. But there are some other molecular markers which can differentiate the two. Need not remember it, just remember that genetics does play a role, and there is something known as a histone 3 mutation. Other terms are very difficult for us to remember, and we need not remember them. As far as histology is concerned, we should be able to understand what the pathologist has written so that we can learn from that and also correlate it, and will also be helpful for us during follow-up. What is the primary cell type? Is it glial or neuronal? Is the mitotic activity high? Is there necrosis? And is there microvascular proliferation? So if there is microvascular proliferation, it indicates high grade. If there is high mitotic activity, similarly it will indicate that it is high grade. Having said this, the age-old differentiation of what is the age of the patient at presentation, what is the location of the tumor, still has great value. There's a very nice 2-series article. I would request each one of you, if you have not come across this or not read this, this is a radiologist guide of 2021. This is in radiology. It has got part 1 and part 2. I found it as an amazing reference for us imaging specialists. And I have taken most of my images from these two. These are peer reviewed, we need not doubt them, and good quality images. Let's see what we can learn from this. Most of these images are classic. When we talk of a GBM, if you see something like this, an irregular ring, most infections will have a regular ring. If there is an irregular ring, there is an edema, there is a mass effect, and the patient is elderly, that means beyond 40, 50 years of age, think of GBM. There will also be areas of restricted diffusion. This is another thing that we should know of, what is known as a T2 flare mismatch. This of late has been cited as a diagnostic marker on MR imaging. Usually, a pathology is hyperintense on T2, and if it is fluid, clear fluid, it will invert on flare. We do not expect a glioma to be inverting on flare, it is not fluid. But if you see that it is bright on T2, but dark on T1, this is seen in about 50% of astrocytomas, but if it is seen, this is an astrocytoma. This is a very good sign, and this is known as a T2 flare mismatch. As far as an oligodendroglioma is concerned, the signature is this kind of curvilinear calcification. So, it is a good idea to get an NCCT done in tumors, even if you have got an MRI done, because calcification is best and most easily understood by us on a CT scan, even by the surgeons. Though we have SWI which can give the answer, but CT scan is the easiest to understand, and just a non-contrast CT scan, you have to do it only once. So if you see this kind of a calcification, very difficult to describe when you already have an image over there. You see this kind of a calcification, please think in terms of oligodendroglioma. This is another case which I found very interesting. That at times in a tumor, you may see that the size has reduced. The edema has reduced. And the patient has not even undergone any treatment. How is it possible? The answer to this is if the tumor is causing seizure, which is one of the commonest presentation in tumors, a patient who has been imaged soon after having an ictus or a seizure in up to 2 to 3 weeks will have edema, and the tumor will look larger. You do the imaging later, maybe after 2 years, 3 years, 5 years, you may see that the tumor is small. The reason for a tumor which looks big and edematous and more angry in an earlier image than a later image, please remember this, it's because of the effects of a recent seizure. There is another new term which has come up, polymorphous low-grade neuroepithelial tumor of the young, PLNTY. In this, what you have is these kind of circumscribed small cysts and calcification, cortical based. So if you have this tumor, this is a PLNTY. This is a signature image of this. Another signature image is an angiocentric glioma. In this, what you see is a band kind of a thing going towards the center. This does not need any biopsy. Maybe for last 2 decades, as Osborne has also been telling, that this is diagnostic. All you do is just do an MR spectroscopy. If you're high choline, it's a pontine glioma. As far as metastases are concerned, these can be great mimickers. What is important to know about metastasis is the last sentence. There will be an increased choline in the adjacent edema, in a glioma, but not in a metastasis. Brain mets, best sequence to do is a 3D FSE sequence. There is something known as a myxoid mesenchymal tumor. If you see a brain tumor which is really bright on T2, think of myxoid mesenchymal tumor. This is another entity which has a signature image. This is multinodular vacuolating neuronal tumor. You see something like this. Small hyperintense cyst-like lesions in cortical base. Think of this tumor. A mixed oligodendroglioma, if you see this kind of calcification, think that oligodendroglioma is present. Ependymal tumors, these are joining the ependyma, hypointense on T2, restricted diffusion. Melanocytic tumors, hypo on T2, hyper on T1. Role of perfusion. Tumors will invariably have a higher CBV than the adjoining white matter, a very general statement. Hypercellular tumors will have restricted diffusion. We should know about MR spectroscopy, very nice talk given. We should know where they are, and we should know one sentence about each of them. What is important is that in an IDH mutant, you will have 2-hydroxyglutarate peak, which is at 2.25. Alanine, in a good spectrum done, you will see an alanine in meningioma. And you will see a taurine peak at 3.4 in medulloblastoma. As far as tumor pseudoprogression and progression is concerned, or radionecrosis is concerned, in a radionecrosis, or wherever the patient is getting better clinically, please think in terms of pseudoprogression. So this clinical correlation is very important. Certain things, just to remind you, please remember about age at presentation available in all standard textbooks. This is a key factor. For the shortage of time, I'm not repeating them. Similarly about location. You combine age and location, lot of your differential diagnosis will go down. You could take a photograph of this. Then we should know what are the tumors which do not enhance. What are the tumors which have vivid enhancement, like meningiomas, metastasis, CNS lymphoma, hemangioblastoma, the vascular nodule, schwannomas. Which are the tumors which are predominantly cystic, like a pilocytic astrocytoma, a hemangioblastoma. Astrocytoma, the wall will enhance. In a hemangioblastoma, the wall will not enhance. Then we should know there are certain cystic metastases, especially from RCC and melanoma. Then we should know which are the tumors in which we commonly see calcification, like the oligodendroglioma, craniopharyngioma, and most important, certain metastases which can calcify, like from the osteogenic sarcoma, lung, breast, and colon, and the mucinous. Of these, remember the osteogenic and the mucinous adenocarcinoma. Then intracranial extraaxial tumors with calcification. That's another category. Have that list with you. Have a list of tumors which commonly bleed. Have a list of those tumors in the brain which have florid edema and those which do not have edema. Do a spectroscopy and look for that signature. Otherwise, routinely you will have reduced NAA, creatinine will be there where it is, and a choline will increase. This is run of the mill. But if you get an alanine peak at 1.48, you get a taurine in medulloblastoma, and increased myoinositol in low-grade gliomas. Most of the rest of the MR spectra would be similar. Then we should know brain tumors which have restricted diffusion, like the CNS lymphoma, ependymoma, epidermoid cyst. Next, which are the tumors which have reduced CBV? Most tumors have got increased cerebral blood volume. So a signature could be which are those tumors which have reduced CBV? Obviously the low-grade glioma related to the high-grade glioma, but the neuronal tumors, they are known to have reduced CBV. Similarly, radiation necrosis. There is another element in perfusion known as K-trans, which talks about the permeability of the vascular walls. Know which are those tumors which have, most tumors will have, high-grade tumors will have high K-trans. So what's the takeaway? Combine all the imaging information, use distinctive features as I listed, do a clinical correlation. But remember that it is histopathology, immunohistochemistry, molecular genetics have the final say. Thank you.